According to the Associated Press, the COVID-19 pandemic has killed more than 639,000 people worldwide since it surfaced in China late last year, with more than 15.8 million people infected. This was their tally that they concluded yesterday. South Korea has now reported its highest figures in 4 months, and North Korea has finally acknowledged its first case. And yet, there is a sense that we are coping, and that we are coping largely very well. This is your Sunday Synthesis podcast with me, Howard Feldman. Good morning. It's Sunday, the 26th of July. Joining us each Sunday, as he does, is pulmonologist and frontline expert, Dr. Anton Meyberg. Good morning. Are we coping?
Good morning. So that's quite a loaded question, but I think the answer to that is yes, we are coping. If we look at the worldwide numbers hot off the press at the moment, there are currently 16,213,815 cases worldwide, with 648,606 deaths and 9.9 million cases resolved. The United States has 4.3 million cases with 149,000 deaths, and South Africa has 434,200 cases with 6,655 deaths. There were 12,204 new cases reported in the last 24 hours, and there are 263,000 recoveries noted. Currently, there are 5,131 cases in hospital in Gauteng, with 521 of them in ICU and 270 of them being ventilated.
All right, so let's just start off talking about what is happening at the hospitals. Lots of questions around hospital stays and how that is how people are managing. One of the questions people are asking is, what is the average length of stay in hospital?
So it's very hard to give an average of that. It depends how sick the person is. If the person is requiring oxygen, if they need oxygen to go home with, we can say baseline stay anything from 5 to 7 days.
All right. And obviously that most people, well, I would imagine most people are in the normal wards, because you've got the normal wards, you've got high care, and you've got ICU.
So the majority of patients in the normal ward is someone who's actually able to cope on a low amount of oxygen or no oxygen at all. Someone who's in high care or someone who's in ICU needs a higher flow of oxygen. Generally, they need what we call high flow oxygen or non-invasive oxygen, or ultimately ventilation. Those type of patients stay in hospital for a much longer time, anything from 2 weeks to 3 weeks, and it's a much longer protracted period.
Okay, and a couple of people saying, and I would imagine that the strain on the hospitals is quite significant because there's no visitors allowed, which means that any form of communication that people receive around their loved ones being in hospital is either, if they're able to speak to them, but otherwise through the medical staff. How are the hospitals managing with this? This must place an enormous strain on them.
This is very, very difficult, not only for the hospital staff, not only for the doctors, but for the families as well. We're seeing issues here where someone's in ICU, they're on a ventilator, and the family can't come and visit the patient because of the fact that they had a high potential to get infected with the coronavirus, and they have to rely on nursing staff or other auxiliary staff to give them messages. What does happen in most instances is the doctors are keeping in contact with those patients on a daily basis if they are severely ill, but the patients who aren't critically ill are being telephoned by the nursing staff, or the families are phoning the nursing staff to get updates. This, however, is not the best ideal, because it would be far easier if the family could ideally see the patient and come into the hospital.
Yeah, but unfortunately they can't. It just adds another layer, I would imagine, that the hospitals haven't been geared up for, because this isn't how a normal situation works.
No, normally, as I say, the patients can come get visitors 2 times a day, or if they're in ICU once a day, but at least they get that interaction with family members. It's a very lonely journey what the patients are going through at the moment. Very hard, very difficult.
Right, and for the families, of course, as well. What is the latest in terms of treatment? What are you using? What are you seeing? Have you changed some of your protocols?
So our protocols are much the same at the moment. We're still waiting for remdesivir to come in so we can help decrease the morbidity in the hospitals. We are still using dexamethasone or other related corticosteroids, other types of cortisone. We are still using oxygen or half-flow oxygen. We are still using our same vitamin cocktails that we were using before, and other medications like melatonin, statins, and other types of medications to try and help. There are a lot of new studies coming out with different types of medications, things called fibrates, which work on the carbohydrates and try to prevent the accumulation of carbohydrates in the lung cells. This is not a peer-reviewed trial. This was done at the Hebrew University. This is being looked into to see if this will help benefit people who have got COVID-19 with severe lung disease.
Can you just talk about melatonin for a moment? Those of us with kids with ADD have used it or used it when they were younger as a way to help them sleep a little bit better. Why melatonin? What's that?
So it's postulated that it's got some antiviral, some anti-inflammatory effects, and it helps with the sleep cycle at nighttime. And this helps with the whole duration of the actual treatment of the virus to help people's hormones and inflammatory markers and viral markers settle down. It's not a treatment. It's
Right.
not a treatment, but it definitely helps in the whole armamentarium of drugs that we use together to try and treat this whole process.
Would you recommend some people use melatonin at night at home if they are not ill?
No, not necessarily.
Okay. So right now, the preventative treatment or the best thing you can do remains, and I know we repeat this every week, but I do think it's that important. What should people be taking at home?
So if you are sick, if you are COVID positive and you're at home, you need to be on your vitamins, vitamin C, vitamin D, zinc, nicotinamide, thiamine. Those are the basics of what you need to be using at home. If you're requiring oxygen or if you are much sicker, then you need to be in hospital. And there, when you're treated, you'll be given treatment like oxygen or corticosteroids such as dexamethasone or other medications. And you'll have other treatment added such as statins, such as melatonin, all other things to try and help you with this virus.
Prophylaxis we should be taking?
Look, I believe that everyone should be on a good multivitamin. Once again, flu vaccine, very important. Pneumonia vaccine, if you've got comorbidities and you're over a certain age, of the age of 65, definitely important. And you should be taking a good multivitamin such as Berocca, Centrum, any of the Vitafines, any of those multivitamins that can give you good, broad sort of coverage.
Does the pneumonia vaccine, and we've got a few questions around this, does it help prevent any further complications if people have had it?
So the pneumonia vaccine and the flu vaccine don't treat the COVID virus. They do help prevent in getting severe pneumonia, severe pneumococcal pneumonia, especially people who have got high comorbid disease like people with severe COPD or people with asthma. Those are people who tend to get much sicker with respiratory viruses, and people who have got treated with influenza, the vaccine, that also helps in preventing the influenza. As of this point, we still haven't seen any influenza cases going on in the hospitals, but I think that's largely due to the fact that people are still staying indoors, washing their hands, wearing masks, etc.
There's also been talk about this cholesterol medication. I think you mentioned it last week, the study in Israel.
I actually just mentioned it now, the fibrate. That's the one I was talking about.
Okay.
Yeah, and that's not peer-reviewed. So we can't go and say that everyone should be taking a fibrate now. It's still being looked into. It does work on the carbohydrates that attack the cells in the lungs, but we're not sure if it's got any benefit as of yet.
Okay. A fair amount of concern as well around people convinced that they've either received a false negative or they get a negative result and then only later on find that they were positive. What is your experience with this?
So I think you've got to put your clinical acumen as a person into play over here. If you are sick and you've had a negative swab, and then you go for another swab and you still get another negative swab, remember that there's a 30% yield. In other words, 30% of people will not get a positive swab on their actual swabs. So if you are still feeling sick and you think you've got the virus, rather isolate, rather stay at home. Keep yourself away from people for that 14-day period when you are feeling sick so that you cannot infect other people. If you are getting sicker and you're still not feeling well despite a negative result, speak to your healthcare worker, discuss it with them, and they'll advise you what to do further.
So we're seeing false negatives. Are we seeing false positives?
We do see a fair amount of false positives as well. But a false positive is better to have than a false negative, for the fact that if you've got a false positive, you're still isolated, doesn't mean you're sick. If you've got a false negative, you still could be sick and you still could spread the virus. So we're far more worried about the false negatives. if you have got a positive result, whether it be false positive or positive, you've got to be careful because we still don't know what the antibody response of the body is yet.
All right, let's just talk about that because a lot of, a fair amount of questions around the antibody tests that people are doing, the studies through Wits University. Is it safe? Should people get involved in it? What's your thoughts around it?
There's a large amount of studies being done at Wits for the vaccine, and I think it's a very good idea. If you're a healthy person, if you've got no comorbidities, they need people to come and go forward and volunteer and be tested either with the placebo or with the actual vaccine. With regards to antibodies, once again, we don't know how long the antibodies will last with the COVID-19. It's not like measles where you get lifelong immunity. Here, this could be a few weeks to a few months, but to less than a year, but we still don't know. It's still a novel virus, so we're still learning day to day. We have heard, as we discussed before, of people getting reinfected 3 months later, and that we're not sure if it's a residual infection, if it's a reinfection, or if it's an exacerbation of the same virus. So we're still learning, and we've still got lots to learn about this virus.
So anybody that's had it should not, and I know we repeat this every week as well, but I think it is equally as important. Don't assume that you are now protected. You've still got to wear a mask. You've still got to be careful.
Once again, you do not have an immunity passport once you have been infected. It doesn't mean you can go out and expose yourself to the virus again because we do not know what it will do to you.
Is it likely that most of us are going to land up having had COVID-19?
So in order to get herd immunity, that would be the likely answer. It's not likely if we keep indoors and we observe the lockdown and we wear masks and we observe the social distancing and we wash our hands. It is probable that we will get infected if we spread around and keep with other people and socialize and go to dinners, etc. But, we're not sure of the majority of people getting the virus if they're going to be staying at home.
Right. Are you seeing a pattern? Because and I don't know if this is anecdotal evidence or not, or if it's just an anecdotal experience, is that there's certain people that I know that have been COVID positive, that had comorbidities that one would have thought would have suffered greatly during whilst positive, and they haven't. And yet others that seem to be younger, healthier, have landed up in hospital with severe symptoms. Are you seeing are these exceptions, or are you seeing this? Are you seeing no pattern here?
So the pattern is that there is no pattern. We just cannot tell. Certain people will get infected. You can be in a household with your husband or your wife, and the husband is positive and the wife is negative. What we are seeing, and new studies are showing us, is there's what we call a TLR7, a toll-like receptor 7, that has got an abnormality in the genetic studies, and we find those people are the ones who are more prone to getting infected. In other words, if they've got a genetic abnormality or aberration in their actual genes, they've got a higher chance of getting the virus. We don't know who's going to get the virus. We do know that people with comorbidities and multiple comorbidities definitely get sicker with the virus, but it doesn't mean because you've got a comorbidity that you are going to get the virus.
Right. Okay. Can we isolate that? I mean, can we test for that gene?
You can't test for that gene. It's extremely expensive. It's not something that's done like a baseline blood test, like a full blood count or a kidney function test. That's only done in certain labs overseas in the genetic studies, and it's not an easy test to try and find out. So it's not exactly easy.
Okay, so it's not something that we... a few questions as well. If somebody suffers from hypertension, diabetes, etc., but it is under control, they're medicated, they are well controlled, is this still considered a comorbidity?
So I think that's a very important question, because the point is, and this is a very important point, you have to keep your comorbidities under control. You have to continue taking your chronic medication. It still is a comorbidity. You still have got hypertension, which is high blood pressure, or you've still got diabetes, or you've still got COPD/emphysema. Those are still comorbidities. But by the fact that you are taking care of yourself and keeping it under control, there's less a chance of you getting sicker. If your comorbidities are out of control, in other words, if your sugars are very high, or if you don't look after your blood pressure, then when you do get sick, you've got a higher chance of getting much sicker.
A couple of questions around which I hadn't seen before about UV lights or UVC lights. Also questions about, in China we saw images when the virus became a thing, that they were disinfecting streets, and they were. We haven't seen any of that here in South Africa. Is that because it's pointless?
Well, we use UV lights in the hospital. Okay, we've
Right.
got UV robots which come into a room when a patient has been there, that's been positive. Once a patient leaves, the room is given that UV light. It takes a few minutes and it completely irradiates the room. So obviously no one can be in that room at the time, and the room is irradiated and gets rid of all the bacteria and viruses from those rooms. The UV robots go to doctors' rooms. They go throughout the hospital to irradiate the hospital and make sure there's no germs or viruses or bacteria in those areas. With regards to spraying, a lot of people are using hypochlorite acid to spray the areas that are not toxic to humans, but do actually get rid of bacteria and viruses and funguses all over the areas. I'm not sure why we're not using it in the streets at the moment, but I don't think we need to in certain communities.
Okay, so there is certainly some value in it.
Yes.
A few people asking the question around air conditionings and heating units, because we now may be a little bit more confused around whether this virus is airborne or not. Should people be using air conditionings in offices? Should they not be using heating? Can you give us your sense or your current understanding?
So I think the whole discussion of the airborne spread of the virus came from these people who were singing in a choir. People didn't have masks on. They were singing in a small area with people not wearing masks, and there was a super spreader who spread the virus due to high aerosol spread of the virus when they were singing. We don't believe you should be using air conditioners unless you've got a HEP filter which can actually recirculate the air and get rid of the virus. The problem with the normal virus is that with a normal air conditioner, you're recirculating the virus throughout the office. So we don't want people to use air conditioners or heaters. That's anything that's going to promote the virus in those small contained areas.
So rather use a normal heater if you're cold, rather than one that is circulating.
And the air filtration, yeah,
right,
correct.
Right. Okay, and somebody asking about non-invasive ventilators. Are they coming to South Africa soon? What is a non-invasive ventilator?
So a non-invasive ventilator is a tight sealed mask that puts the positive pressure ventilation into the airways. This is commonly used in a high care unit or commonly used in an ICU unit. They're not coming to South Africa. They are in South Africa. We're using them all the time.
Okay, so that's good. Can we just talk about as well about travel? Because as things are opening up a little bit more in South Africa, I know a number of people traveling to Cape Town, to Durban, domestic travel. What precautions should they avoid aeroplanes at this point, airports and aeroplanes, if they possibly can? And if they do have to travel, how should they be dealing with this?
So the airports and the airplane guidelines say that they've got these special filters on the airplane that can filter out all the virus. I myself wouldn't personally travel in airplanes at this point in time. Remember, we had over 12,000 new cases yesterday, the majority of it being in Gauteng, and obviously there's a low amount in the Western Cape, but this virus is still rampant. It is still spreading everywhere. Don't take the chance. Don't try and spread it. But if you do have to travel, then wear your mask, social distance. You're obviously not going to sit next to somebody on the plane. You're going to distance yourself from them, but you have to wear a mask the whole time and stay away from people as much as possible.
Do you foresee that by December, when people want to go on holiday or they want to travel, that they will be able to do so? Would you recommend that instead of flying down to Cape Town or Durban or wherever one goes on holiday, that one rather drives? What's your current thinking? And I know this changes every week and as this develops. I'm not saying that this is set in stone, but just your current thinking.
Look, it's a tough question. I think if people are going to fly down in December, if we have gotten over the virus by then, please God, and we're able to go to different provinces and travel overseas even maybe, I don't think the planes are going to be full. I don't think there's going to be a large amount of people sitting next to each other. They're going to space people on the planes, even with their filters. So I think a majority of people won't be able to travel down, and it'll probably be more expensive to travel due to the fact that there'll be less people on the planes. So I think a large majority of people will be driving down to their holiday destinations if they are able to go.
And would that be safer, though, in terms of the virus? Obviously, it would be, because
I think so.
there's
I think so.
only the owner
If you're in your
exposure.
own contained pod, basically in your car.
Right, and provided that you don't land up killing any of your children, your survival rate would be would be potentially a little bit higher. Right. I get that. In terms of schools, we've now seen that the president has announced 4 weeks. We already discussed last week that some of the Jewish day schools that you're involved with and you're advising had closed, and these discussions are going to be taking place every 2 weeks. What is your current thinking around schooling?
Look, we're looking at the surge in the community and the surge in the area. We do review it every 2 weeks, looking at the numbers. And a lot of people and a lot of pediatricians are saying it's crazy that people should still be going back to school. And that's great from a pediatrician's point of view for the children. But we've also got to look at the adults. We've got to look at the teachers. We've got to look at the staff. We've got to look at the people who are traveling to school via taxis, in a full taxi with full capacity. These are the people who are at risk. The children are not at risk. We know that. And obviously, we'd want our children to be back at school. It will decrease the anxiety. It will be good for them. It will be good for their academic support and their stability. But we've got to worry about our older population. And those are the teachers and the staff and the auxiliary staff. And those are people who we have to take care of at this point.
Right. I just want to focus for one moment on our Jewish community listeners. There's a Jewish fast day, a religious fast day coming up this week. We would ask the same question, I would imagine, for Ramadan, but I think timing was fortunate for those of the Muslim faith, because they managed to get through Ramadan before the virus hit South Africa. What's your advice around fasting for religious reasons, or in any faith? But I ask that because there is a Jewish fast coming up this week.
So we've got to go with our Beth Din, which is our body that controls the religious aspects of our society. And they are advising that people with comorbidities, or people who have tested positive, or people who are recovering shouldn't be fasting. And I have to agree with that. I think if you are sick, or if you've been sick recently within the last week and you're still not 100% better, or if you've got comorbidities and you're over a certain age, let's say over the age of 60 with comorbidities.
I was going to say, you wouldn't go with 20 or 30.
I wouldn't go with your age either. I'm not going to say your age of 69 on the air, but I mean, I wouldn't say that on the air, okay? But I do believe that you got to take care of yourself. You got to look after yourself. And if you're worried and you don't think you should be fasting, phone your local Orthodox rabbi, or phone your local rabbi from any discipline, and let them discuss it with you and tell you the pros and cons of fasting and if you need to fast.
So just to go back again, the age that you would start to get a little bit concerned about somebody fasting?
Over the age of 60 and with comorbidities.
And with
comorbidities. Obviously, someone over the age of 50 with comorbidities that are not controlled is also a problem. But if you're over the age of 50 and you have got comorbidities and you are controlled, then it should be like any normal fast.
Right. Okay. So that's obviously an important one, and one that applies to any religion or anyone that adheres to that. Other questions that we are seeing, the steroids, the inhaled steroids. Again, we spoke about it last time, but the question keeps coming up, and that means not everybody is aware of your view on this. Please, can you take
So there's two aspects to it now. The one is the steroids that are given through a nebulizer. That's taboo. You cannot do that. You are spreading the virus. It's a droplet virus. You're aerosolizing the virus and spreading it. The new studies have come out, and this is what we've been doing in the hospital for many weeks now, is to use a spray that you use with a spacer, and you put directly into the patient's mouth. And then you can give them an oral corticosteroid through the spray. It's contained. It's not spreading anything. The patient's inhaling that. There's been a lot of studies about budesonide and cyclizumab, which are two corticosteroids, which are inhaled steroids through a spray that can be used to treat this virus. And we are using them in people who are short of breath and are wheezing who are in hospital.
Right. Rakhadi on Twitter wants to know, she says, are there similarities between TB and COVID? Because I keep thinking a lot of the messaging around staying safe would have been more effective if we took lessons from TB, the precautions, home care, etc., as people in South Africa are familiar with TB. What's your thoughts around that?
So remember, TB is definitely airborne. COVID is maybe airborne, but definitely droplet spread. So for TB, you have to be much more careful in an open area because the virus or the bacteria lingers in the actual area for a long time. With COVID, it's not as much. But Rachad, you're right. You have to take care of yourself. You have to wash your hands. You have to wear your masks. You have to stay away from people. You have to keep your nutrition up. You have to look after your health in all aspects of the way. So there are some similarities, but they're both very divergent diseases that cause different types of damage. They both can affect the lungs. They both can affect multiple organs, but they can go in different pathways.
If we look at how South Africa is doing in general, we know that the Eastern Cape is severely problematic. The reality is that the Eastern Cape was problematic before COVID, and the medical system, the medical infrastructure within the Eastern Cape was very, very compromised and hardly efficient. You can really speak for Gauteng only. That's your experience. That's where you connected with various private and government public hospitals and the people working therein. How are you finding that we are doing?
So I think we're taking strain on many aspects. The government hospitals are full, they're overcrowded, and there are a lot of sick people. People are getting the care, but there are some places where they've got to wait much longer than they should be waiting. But that's due to bed availability, and that's due to just general constraints. The private hospitals are managing very well at the moment, and they are taking overflows from other hospitals to try and curtail this need of people having to wait for beds. So I think we are coping very well, and I think we are doing very well, but we've still got a long way to go.
In terms of field hospitals in Gauteng?
So the one in Nasrec is apparently open. As I said, they don't have oxygen at that field hospital, but that's a place to send people who are mildly sick, that can't go home straight away after hospital, and this is a place for them to convalesce.
Right. How far are we from the peak, do you think?
You know, it's difficult to say. I think over the last few weeks, we've been sitting at 12 to 13,000 a day, some days a little bit less. I think we need another week or two to understand where we're going and what's happening. As it's getting colder now, we might see other viruses kicking in as well. So, I mean, if you look at the Western Cape, they're seeing a massive improvement in their numbers. They're seeing a lot more people that are getting better clinically. So hopefully we're going to get there soon.
Right. And from my observation of you and how you are managing, it certainly seems as though things are under some form of control, that it's stabilized. Is that observation correct?
Well, I think you've got to understand that it depends on where the doctor is in the whole process. So if you're on call, then you're getting lots of admissions. If you're not on call, then you're managing the cases that are in the hospital and not seeing the new admissions. So albeit it looks a little bit better, which it really does look a little bit better, it depends on how often you're on call taking in new admissions and seeing those new admissions and treating them.
Right. Is there good news?
So yes, there is good news, but I'm actually going to quote from Dr. Anthony Fauci. I think this is very pertinent what he says. I'm actually going to read what he said. He said, "You know, this is so stressful for all of us. I think we have to remember that we're going to get through this. This is not something that's going to be forever. It's going to be over. And we are going to look back and say we really gave it our best shot. But science and good biomedical research are also going to come to the rescue because we are going to get a vaccine, hopefully sooner than later. And we will get effective therapeutics. We are all in this together, and we are all going to get through it." And to quote Sun Tzu, "The supreme art of war is to subdue the enemy without fighting." And with regards to that, remember, wear your mask, wash your hands, social distance, stay away from people, stay away from dinners, look after yourself, look after each other. We have a community responsibility to look after each other. Be safe and be well.
Thank you, Dr. Anton Meyberg. I'm Howard Feldman. This has been the Sunday Synthesis podcast. We do this every Sunday. We answer your COVID-19 questions. Stay safe and wash your hands.